Now, we are moving away from cancer, but we stay on recurrences because that's also a relevant clinical problem, particularly in those patients undergoing surgery for benign disease before 40. Now, let's start also with the case history that will, in a certain way, illuminate what we are going to talk about, a recurrent goiter. This is a 62-year-old lady who was admitted with dyspnea in the hospital, and the past history was a right hemithyroidectomy about 30-something years before. She knew she had a recurrent goiter for the last 10 years, but she didn't care much about it. But she developed progressive dyspnea. Finally, she was even diagnosed of a sleep apnea syndrome until she was admitted acutely to the hospital for asphyxia. And she had a large cervical mass pushing the trachea, and on top of it, she had a paralysis of the right vocal cord, which, of course, was related to the surgery performed 30 years before. So she was really in a bad situation, and we did quite an emergency left hemithyroidectomy, and the patient recovered successfully. What's the most common causes of recurrent goiter? The first one is conservative surgery in the young patient. That's the typical situation of a patient coming in the 60s or 70s, having had surgery 20, 30, 40 years before. Also, we have some patients that we call failed thyroidectomies, which is not true recurrence, but the surgeon started surgery and then stepped back because he wouldn't be prepared for doing a so-called difficult thyroidectomy. So we have some of that. Multinodular disease at first operation. If you leave nodules behind, you will have more chances to get a recurrence later on. Family history and treatment, suppressive treatment or substitutive treatment with T4 has not shown to prevent or to increase the chance of recurrence. So for what we know now, the most relevant factors that you should consider as potentially causing recurrent late in life is conservative surgery, less than total thyroidectomy, performed in a young patient, especially if some nodules were left behind. In the past, there were funny operations done for goiter. Nodulectomies were quite common in Europe, at least in Central Europe, for many years. Subtotal lobectomy, that's a funny operation. That should be disappearing. But I still see patients that had subtotal hemithyroidectomy in the past. Hemithyroidectomy, leaving potentially a diseased lobe on the other side, and bilateral subtotal thyroidectomy, which was quite a standard operation until the end of the 80s. Most of these operations have now been substituted by total thyroidectomy or near total thyroidectomy or downhill procedure, which is total and almost total from the other side. And more, these more extensive surgery are done to prevent recurrences. Of course, in the young patient with contralateral subclinical disease, you may consider hemithyroidectomy. We did a trial on that, and in some patients it may be okay, but the risk of recurrence, especially in young patients, is very high, although recurrence may appear 20 to 30 years later than initial hemithyroidectomy. The clinical presentation of recurrent goiter is usually a cervical mass. The patient complains that they have again another lump in the neck. Most of them suffer from compressive symptoms because once you have operated on the neck, the distension of the neck is reduced, and a mass in the neck will cause compression of the veins, of the trachea, of the esophagus, and they will complain of dysphagia or even dyspnea. Vocal cord paralysis is seen in quite a number of patients that had conservative surgery, maybe many of them iatrogenic or even for compression. Mediastinal extension is pretty common in these patients. Hyperthyroidism, Plummer's disease, is seen in about 15%. And finally, cancer cannot be ruled out. The subtitle of my talk is recurrent goiter is not just another lump in the neck, because some people that come back with recurrent goiter have associated diseases that we will cover, especially cancer. Preoperative assessment is essential because if we plan to reoperate the patient, we have to know exactly what was done at the initial procedure. Is the extension, is the recurrence very large? Does it extend to the mediastinum? Does the patient have a paretic cord as a result of previous surgery or because of the goiter? Does the patient have cancer? Because maybe the first surgery was performed many years ago and, he may have a new disease. Not obviously is always recurrent goiter. And finally, because of these recurrences are seen mostly in women, and in women after 50, we should rule out primary HPT that you will see is quite common in our series of recurrent goiter. We will do a comprehensive preoperative assessment, which is basically based on imaging and laryngoscopy. If we can have the pathology reports from previous operations would be great. Thyroid hormones to rule out hyperthyroidism, and always have a cervicomediastinal imaging, because some of these patients, quite a lot of these patients, in fact, have extension to the mediastinum. Fine needle aspiration, serum calcium, PTH, and calcitonin. That's our current protocol to assess patients with recurrent goiter. Let's see some images of patients with recurrent goiter that maybe are, at least for the surgeons, are essential to plan surgery. You have here a couple of images of hemithyroidectomy, and you can see that hemithyroidectomy, recurrence after hemithyroidectomy, can be a very distorting in the neck. The trachea is very much displaced, and you have, in this case, a very large left lobe. Here you see a less pronounced mass, but with heavy calcifications inside. This is the kind of CT scans we always ask for when we evaluate and preoperative assessment of recurrent goiter. In some patients, the whole pyramidal lobe was left behind, and you have here a recurrent on the other side. Again, it's essential that we image well the neck, because the aim of the surgery is always to reach the status of total thyroidectomy. Otherwise, the patient may get a new recurrence. So if we would do just an hemithyroidectomy here, probably the patient would get a recurrence from the pyramidal lobe in 5 or 10 years later. So in this case, we also remove the pyramidal lobe and did the contralateral hemithyroidectomy. Imaging studies that's again another case of recurrence on the thyroglossal tract, which sometimes the surgeon would do a thyroidectomy and leave the whole pyramid up to the tongue. And this is something that we always take care of when you do a surgery for goiter or for cancer, to be sure that we remove the pyramidal lobe, otherwise you may have a recurrence high up on the neck. In this case, the patient had several nodulectomies performed at the age of 18, and 18 years later, at 36, she had a massive extension to the thorax requiring a sternotomy. So remember, when you see a patient that had surgery early on, a young patient, recurrence may be very difficult to deal with, because at that age, recurrence grows really faster. That's the typical image of bilateral recurrence after subtotal thyroidectomy. This is a female patient operated in 1978 of subtotal bilateral thyroidectomy, which was kind of a standard surgery in the 70s and 80s, and she developed 25 years later bilateral recurrence requiring bilateral remnant excision. You see here the stenosis of the trachea compressed by both remnants. Again, another case where the Recurrence was probably due to subtotal bilateral thyroidectomy, although there's a little bit of the isthmus here. But if you insist on having a thoracic CT scan and imaging down there, you see that the tubercle of sucker candle of the left thyroid lobe goes down and down at the level of the aortic arch. So always have the extension to the thorax to be sure that the goiter is not just in the neck, but also going down to the mediastinum. This is, the left remanentectomy of this patient having a very large goiter extending to the aortic arch. Rule out cancer. I mean, not all the patients coming back with a lump in the neck have recurrent goiter. This is an interesting case where a patient was seen in our hospital, 60 years old, and a past history of subtotal right lobectomy, funny surgery for benign disease in 1989. And then she had a lumpectomy for cancer of the breast, and somebody palpated her neck and said, oh, you have a recurrent goiter. But the thing is that in the follow-up, they tested for CEA to investigate her breast cancer and turned out to be 500 with a SUV of 4, normal thyroid function test, and calcitonin was 5,000. So the patient had medullary cancer on the opposite side that was left from the initial surgery. Let's talk about primary HPT. You should always have a serum calcium in all patients undergoing surgery of the thyroid for any disease, but especially if you deal with a population of elderly female. This patient had a bilateral subtotal thyroidectomy 20 years before and had neck radiation in childhood for angioma. And he was at that time being investigated for osteoporosis when she consulted us for a recurrent thyroid nodule on the left, which was causing some compressive symptoms. And serum calcium was high and PTH was high. So this patient had a bilateral recurrence plus a parathyroid adenoma. Now, for surgeons, some advice and some strategies to deal with recurrent goiter, which is not usually an easy procedure. It's important to see whether you are dealing with the first surgical field or the second. If you are doing a contralateral lobectomy, for example, it may be more easy unless it extends to the thorax than if you are going back to a field which previously had been operated by another surgeon. Has the patient a laryngeal nerve palsy? This is essential because if you are going to do an opposite side surgery, you may run the risk of having a bilateral palsy, which is catastrophic, as you know. So it is essential that we know exactly the recurrent, the vocal cord function in these patients. Rule out cancer, primary HPT, and then if you had the possibility of having the pathology report where parathyroid glands resected at first operation, because if you are doing now aiming at total thyroidectomy, in fact, one of the complications of reduced surgery of the thyroid is hypoparathyroidism. Now, when planning the surgical access, we like to say if you need only to approach one compartment, 2 compartments, or 3 compartments. Of course, this is the most common situation, but you really see from time to time huge goiters, recurrent goiters that require more extensive surgery. Now this is the, what I would call the standard approach for cervical approach for remnant excision. This patient has a remnant or almost an hemithyroidectomy, which is not a big thyroid lobe. You can approach this from the midline or from the lateral side. If it's really big, as this case with, again, hemithyroidectomy, you should probably approach this both lateral and medial and probably cutting the infrahyoid muscles. So hemithyroidectomy for recurrent goiter is not always the same. You may have a reasonably small lobe, or you may have a huge recurrence which, despite being an hemithyroidectomy, can be more difficult. Two compartments, when you see that kind, this goiter will never go through the neck incision because, as we say, it has pear shape. If your goiter goes to the mediastinum, it can go as a, ¿cómo se dice zanahoria en inglés? Carrot, that's it. It's carrot or pear. If it's carrot, it will go out from the neck. If it's a pear, it will never go out from the neck. That's our colloquial saying in Barcelona. So in this case, you will need a two-compartment approach with a sternotomy. In fact, when we look at the sternotomies we have done in Barcelona, about 80% are for recurrent goiter. It's very, very uncommon for initial surgery for endothoracic goiter, but not that uncommon for recurrent goiter. That's again another case where two compartments should be were open. Again, pear-shaped goiter, retrovascular, deep down on the neck to the carina, and then requiring really sternotomy and a wide exposure to deliver this goiter through the neck. In exceptional cases, we have a couple of cases, recurrent goiter. In that case is hemithyroidectomy, because the patient had a right hemithyroidectomy, but you can see that the left lobe has reached gigantic proportions, is going between the trachea and the esophagus, goes to the right pleural space. No way to deliver that just through a sternotomy. You need to make a short right thoracotomy to deliver that from the thorax. Now, the risk of recurrent laryngeal nerve injury, it's higher when you redo surgery for malignancy, but then the second most common situation where your recurrent laryngeal nerve runs a risk is recurrent benign goiter. So if you compare the palsy rate between a simple initial surgery for multinodular goiter, you have almost 5 times more common lesion of the recurrent laryngeal nerve if you do a redo surgery for goiter. So this should be taken into account because it's our contention that recurrent surgery for goiter should be done in specialized endocrine surgery units. You have here the palsy rate for recurrent multinodular goiter, and it's really high in comparison with the recurrent laryngeal nerve injuries that you have for first initial surgery. So the mean percentage of recurrent nerve injuries would be something around between 5 and 8%. So we are dealing with a special group of patients having a high risk of developing recurrent palsy after redo surgery. What are the tricks to avoid a recurrent laryngeal nerve injury? Well, the trick in all redo surgery is going first where the initial surgeon did not go in. So go as low as you can in the neck, because that's the dangerous zone. This either for endothoracic goiters, either for remnant excision, this is the dangerous zone, and this is the most, what we call the drive carefully zone, where you identify the recurrent laryngeal nerve very, very down in the neck and then go drive carefully up. And that's the best way usually, or in some cases just the opposite. Try to identify the nerve very high up in the neck, close to the cricothyroid junction, and that for some endothoracic goiters is the preferred route. But never try to go where the surgeon initially had dissected the heart, had approached this area. This is a typical strategy for remnant excision. Now we are going to the thyroid bed where the surgeon was some years before, and what we do is initially we cut the muscles to gain a nice exposure. The second will be to find the inferior thyroid artery and then the recurrent laryngeal nerve. Now, with these structures well defined, you can go easily and then go to the plane of the trachea and remove the remnant. So don't try to identify the nerve very close down here, because this is usually a very scary area where it's difficult to identify the nerve. So move down the neck, identify the nerve, and then go up. If the goiter extends to the thorax, don't try to put your finger and pull it up. Just remove and you cut the upper pedicle of the upper pole of the thyroid, and then you try to identify your recurrent laryngeal nerve high up, and then by cutting the berry ligament and pulling very slowly, eventually the endothoracic portion of the goiter will be delivered to the neck. You see here the inferior thyroid artery, and here you have our identified recurrent laryngeal nerve, and we will do the dissection. We call it a slide down. And then finally, you can deliver that. Neuromonitoring can be helpful in difficult cases. This is the experience by Kerstin Lorenz in Germany, where she worked on injuries to the recurrent laryngeal nerve, with or without monitor, together with Barthinsky's in cases of redo surgery. And then you can see that there is quite a reduction of both transient and even permanent. It's not just a question of paralysis, it's also a question of identifying the nerve. And sometimes neuromonitoring is useful as a tool to improve our localization strategies. Let's go now fast to review our series. We have done 91 reduced surgeries for multinodular goiter. And this is interesting. The age at first surgery, I was telling you before, was pretty young, 39 years. It's very unusual to do a reduced surgery for goiter in patients that were operated after 50. Or after 45. So most of the patients we see with recurrent goiter had surgery at a young age. The age at reoperation was 55, so approximately between 16 and 18 years difference between the first and the second or third operation. Many indications were symptoms of compression. 10% of the patients we had already a paralysis of the recurrent laryngeal nerve, and 10% had significant endothoracic extension. So 8 were iatrogenic, 1 was compressive. So it means that about 1 in 10 patients with recurrent goiter may have a nerve paralysis produced by the initial surgery. Cancer was diagnosed in 9 patients. 2 patients had follicular papillary, 1 had follicular, and 2 had medullary cancer. Primary HPT was observed in 9 patients, so again in 5 patients, so 9% of the cases. 1 was in a patient who had a parathyroidectomy for MEN1, and 4 were sporadic. So still, you see that when you deal with recurrent goiter, you have to rule out other potential diseases. And that's the type of surgery we did. This is the surgical intervention that the patient had 20 years before. Most of them had a hemithyroidectomy, either a right or left hemithyroidectomy. About 15 had subtotal thyroidectomy. Others had nodulectomies, subtotal hemithyroidectomies. 9 had a failed thyroidectomy. The patient was closed, and the patient was sent for reoperation at a specialized unit. 1 patient or 2 had a downhill procedure. Another had a subtotal hemithyroidectomy, and another one had hemithyroidectomy and parathyroidectomy. And that's the operation we did to complete a total thyroidectomy, because that's the aim of reduced surgery, to really get rid of the patient of any residual tissue. We did hemithyroidectomies in almost 50 of our patients, remanentectomies usually bilateral or unilateral in 20 of our patients, double remanentectomies in 10 patients, and total thyroidectomies in 12 patients, including the failed thyroidectomies and those patients that had had just nodulectomies in the past. This is the type of procedures we've done: hemithyroidectomies, total thyroidectomies, remnant excisions, and parathyroidectomies. We did 6 because in one patient we missed the adenoma and we had to reoperate the patient. These are our complications. We had 16 patients with transient vocal cord paralysis, 3 patients with new RLN paralysis, 2 were accidental, and 1 had to be an oncological resection in a patient with medullary cancer involving the nerve. 3 patients developed permanent hypoparathyroidism, 1 bleeding, 1 Claude-Bernard-Horner, and 1 wound infection. So you can see that the rate of complications in reduced surgery, even in referral units, are a little bit higher than those we see in initial thyroidectomy. So in summary, if you deal with potential recurrent goiter, please a comprehensive preoperative assessment, good imaging, always check the laryngeal nerve function, rule out cancer, rule out hyperparathyroidism, and plan the best surgical access with good imaging, preferably a CT scan of the neck and the chest. Total thyroidectomy or total removal of remanent tissue would be the goal of reduced surgery. Individualized identification of recurrent laryngeal nerve, use neuromonitoring in difficult cases, and diagnose and treat all associated conditions. So that's, I think, our rules of the thumb to get success and to be successful when dealing with patients that are not that easy. I mean, some of these surgeries really have a very difficult surgical approach, not only because of the bulky of the of the nodule, but because of the several compartments that can be involved in the neck. And with this, I finish my contribution to the meeting. Thanks again to the organizers. Ready for questions, and thanks for your hospitality, and hope to visit you in the future. Thank you.